Welcome, future nurses, in our daily 3-video challenge. Today we are stepping into a fascinating yet critical area of endocrine nursing, the care of clients with disorders of the adrenal glands. These small but powerful glands sit just above the kidneys and play a vital role in regulating stress response, metabolism, fluid balance, and blood pressure through the secretion of hormones like cortisol, aldosterone, and adrenaline. Disorders of the adrenal glands, whether it is Addison's disease, Cushing syndrome, pheochromocytoma, or adrenal crisis, can quickly become life-threatening if not recognized and managed appropriately. As nurses, our role extends far beyond observation. We must identify early warning signs, anticipate complications, provide safe medication administration, and deliver holistic care that supports both physiologic stability and emotional well-being. By the end of this session, you will be able to link pathophysiology with nursing interventions, prioritize care using safety principles, and apply NCLEX-style reasoning to real-world adrenal scenarios. So let us dive in and strengthen our knowledge, because mastering adrenal gland disorders is a key step toward becoming a confident and competent nurse. Hey, stop for a sec. I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep. Interactive live classes and easy-to-watch, recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, ebooks, and a PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail. During comprehensive lecture. This isn't just another review, it's everything you need in one. Please scan the QR code right now or use the link in the description to enroll instantly and grab free content including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. All right, future nurses, let us continue sharpening your NCLEX knowledge with another high-yield scenario. The nurse is assessing a client with Addison's disease, also known as primary adrenal insufficiency. Based on the underlying deficiency of adrenal cortical hormones, the question asks which clinical findings the nurse should expect to observe. Here are the options to consider. Option 1, salt craving. Option 2, skin blemishes. Option 3, moon-shaped face. Option 4, bronze skin. Option 5, hypoglycemia. And option 6, weight loss. The correct answers are option 1, salt craving, option 4, bronzed skin, option 5, hypoglycemia, and option 6, weight loss. Now let us break this down step by step. Addison's disease occurs when the adrenal cortex fails to produce adequate glucocorticoids, mineralocorticoids, and androgens. This imbalance disrupts glucose regulation, sodium and potassium balance, and leads to elevated adrenocorticotropic hormone from the pituitary. Chronically high adrenocorticotropic hormone cross-stimulates melanocytes, producing the hallmark bronze pigmentation. Looking at option 1, salt craving is indeed correct because aldosterone deficiency causes sodium loss through the kidneys, resulting in hyponatremia. The body compensates by driving a strong craving for salt, which is a classic finding. Shifting to option 2, skin blemishes are not a feature of Addison's disease. Instead of acne-like blemishes, these clients develop diffuse hyperpigmentation of the skin and mucous membranes. Moving on to option 3, a moon-shaped face is characteristic of Cushing syndrome where cortisol is in excess, not Addison's where cortisol is deficient. Next is option 4, bronze skin, which is correct and one of the most distinctive findings. Increased adrenocorticotropic hormone stimulates melanocyte activity, giving the client a tanned or bronzed look even without sun exposure. Considering option 5, hypoglycemia, is correct because cortisol deficiency interferes with gluconeogenesis, making blood glucose levels drop, especially during fasting or stress. Finally, option 6, weight loss, is also correct. Lack of cortisol and aldosterone leads to poor appetite, nausea, vomiting, and fluid imbalance, all of which contribute to progressive weight loss and muscle wasting. Additional signs that often accompany Addison's disease include hypotension from sodium and fluid loss, hyperkalemia due to impaired excretion, and profound fatigue with muscle weakness from electrolyte imbalances and poor energy metabolism. In emergencies, Addisonian crisis can occur, presenting with severe hypotension, shock, hyponatremia, hyperkalemia, and hypoglycemia, a life-threatening situation that demands immediate intervention. And here is your Stancoast Pearl to remember it easily. Bronze, salt, skinny, sugar low. Clients with Addison's disease show bronzed skin, salt craving, weight loss, and hypoglycemia. 4 hallmark signs that will guide your NCLEX answers and clinical judgment. Let us move forward into another high-yield NCLEX practice scenario that focuses on Addison's disease. A nurse is monitoring a client with Addison's disease during routine rounds, and the question asks which nursing assessment finding provides the most reliable information for evaluating the client's current disease status and guiding immediate clinical decision-making. Here are the options to consider. Option 1, blood pressure. Option 2, bowel sounds. Option 3, breath sounds. And option 4, heart sounds. The correct answer is option 1, blood pressure. Now let us carefully walk through why blood pressure is the correct response. Blood pressure is the most valuable assessment in Addison's disease because the underlying defect is adrenal cortical hormone deficiency, particularly cortisol and aldosterone. Aldosterone is essential for sodium and water reabsorption in the kidneys, while cortisol maintains vascular tone and responsiveness to catecholamines. Without these hormones, the client develops sodium loss, dehydration, hypovolemia, and hypotension. Monitoring blood pressure trends allows the nurse to evaluate both stability and adequacy of replacement therapy. If the therapy is inadequate, the client may progress into Addisonian crisis, which presents with severe hypotension, shock, cyanosis, fever, and electrolyte imbalances, such as hyponatremia and hyperkalemia. This makes blood pressure the single most reliable barometer for clinical decision-making in Addison's disease. On the other hand, let us analyze why the other options are not correct. Option 2, bowel sounds, is not reliable for disease evaluation. While clients with Addison's disease may experience anorexia, nausea, or abdominal pain, bowel sounds fluctuate with medications and electrolyte changes, not directly with disease severity. Moving to option 3, breath sounds. These are usually unaffected in Addison's disease unless there is a complication like aspiration pneumonia or infection due to steroid use. They do not provide insight into adrenal hormone deficiency. Finally, option 4, heart sounds, are not typically abnormal in Addison's disease. Murmurs, gallops, or rubs are not associated with adrenal insufficiency. Cardiovascular compromise is better evaluated through blood pressure and pulse rather than auscultation. From a clinical teaching perspective, remember that Addison's disease is defined by deficiency of cortisol and aldosterone, leading to hypotension, dehydration, hyponatremia, hyperkalemia, and hypoglycemia. Addisonian crisis represents a medical emergency with vascular collapse and shock, requiring rapid intravenous fluids, corticosteroids, and electrolyte management. Daily nursing care should emphasize orthostatic blood pressure checks, strict intake and output monitoring, and continuous evaluation of fluid and electrolyte status. Here is the Stancoast Pearl to lock this in your memory. In Addison's disease, the blood pressure is the barometer of stability. Whenever you see blood pressure trending downward despite treatment, suspect inadequate hormone replacement or impending Addisonian crisis. Now let us transition into another high-yield scenario on Addison's disease. The question asks, a client diagnosed with Addison's disease has been prescribed a high-sodium diet as part of the treatment plan. During meal planning, the nurse assists the client in selecting the best available food item to help meet the prescribed sodium intake. Which of the following should the nurse recommend? Here are the options to consider. Option 1, graham crackers. Option 2, cheddar cheese. Option 3, raw carrots. And option 4, canned fruit. The correct answer is option 2, cheddar cheese. Moving forward into the rationale, cheddar cheese is the best choice because it is naturally high in sodium, which is essential for clients with Addison's disease. Addison's disease results from adrenal cortex insufficiency, leading to deficiencies of cortisol and aldosterone. Normally, aldosterone promotes sodium reabsorption in the renal tubules and potassium excretion, but without it, clients lose large amounts of sodium, leading to hyponatremia, dehydration, hypotension, and even Addisonian crisis. A diet rich in sodium directly counteracts these losses, and dairy products, particularly aged cheeses like cheddar, are concentrated sources of sodium, making this the most reliable dietary option. Looking at why the other options are not correct, Graham crackers may contain hidden sodium, but their sodium content is minimal compared to cheese. For example, 2 graham crackers provide only a fraction of the sodium found in 1 ounce of cheddar cheese, making them insufficient to meet therapeutic needs. Raw carrots, while excellent for vitamins and fiber, are naturally low in sodium and therefore not useful in addressing hyponatremia. Canned fruit, on the other hand, is very low in sodium, but often higher in potassium, which can worsen the elevated potassium levels already common in Addison's disease, making it the least effective choice. Finally, connecting this clinically, sodium replacement is a critical aspect of Addison's management, alongside lifelong glucocorticoid and mineralocorticoid replacement therapy. Nurses should emphasize that during times of stress, illness, or hot weather, sodium needs rise further due to increased fluid and electrolyte losses. It is essential to teach clients to monitor for early warning signs of hyponatremia, including dizziness, salt cravings, hypotension, or confusion, and to select sodium-rich foods consistently. And here is your Stan Coast Pearl to lock this in. Addison's needs salt to survive. Think cheese, soups, pickles, and salted snacks as safe sodium boosters, while avoiding low-sodium fruits and fresh vegetables when sodium levels are low. Let us now move forward into another clinical reasoning scenario. A client with Addison's disease is experiencing recurrent episodes of hypoglycemia despite being on a regular diet. The nurse wants to provide a between-meal snack that will help stabilize the client's blood glucose levels and prevent further symptomatic dips. The question is, which of the following options would be the best choice to promote sustained glycemic control? Here are the choices to consider. Option 1 is lemonade and peanuts. Option 2 is cola and potato chips. Option 3 is coffee and a muffin. Option 4 is milk and crackers. The correct answer is option 4, milk and crackers. This is the ideal snack combination because it supplies both complex carbohydrates and protein. Crackers provide starch, which breaks down slowly and steadily releases glucose into the bloodstream. Milk contributes lactose, protein, and fat, all of which slow gastric emptying and promote stable blood sugar over time. In Addison's disease, adrenal cortex insufficiency leads to cortisol deficiency. Cortisol is essential for gluconeogenesis and for maintaining blood glucose during fasting. Without it, the body cannot mobilize glucose stores effectively, leaving clients vulnerable to hypoglycemia. Therefore, snacks that pair protein with complex carbohydrates create a slow-release energy effect, shielding the client from rapid fluctuations. In addition, dietary management in Addison's disease includes scheduling frequent balanced meals or snacks, ideally about 6 per day, to prevent hypoglycemia crises. Turning to the distractors, option 1, lemonade and peanuts, may look helpful since peanuts add protein, but the lemonade is made mostly of simple sugar. This produces a rapid glucose spike followed by a steep crash, which is unsafe for Addison's disease clients. Option 2, cola and potato chips, is also not appropriate. Cola is loaded with simple sugars and caffeine, leading to quick swings in glucose levels. Potato chips are high in fat and sodium but offer very little protein or complex carbohydrate. While sodium replacement is important for Addison's disease due to aldosterone deficiency, this snack does not serve the purpose of stabilizing blood glucose. Option 3, coffee and a muffin, may seem filling, but it fails as well. Coffee contains caffeine, which stimulates catecholamine release and may mask hypoglycemia, warning signs like tremors or palpitations. The muffin is high in refined flour and sugar, causing another spike and crash cycle. Altogether, this option lacks the balance of macronutrients needed for sustained energy. Here is your Stan Coast Pearl. Remember the phrase, protein plus complex carb equals hypoglycemia shield. For Addison's disease clients, the safest between-meal snacks are those that combine protein, like milk, yogurt, cheese, or nuts, with complex carbohydrates, such as whole grain crackers, cereal, or bread. This combination creates a steady release of glucose and prevents dangerous blood sugar swings that could trigger Addisonian crisis. Now, let us move into a clinical teaching moment about Addison's disease and crisis prevention. The question is, a client diagnosed with Addison's disease is being discharged with education on preventing Addisonian crisis, also known as acute adrenal insufficiency. Which instruction should the nurse prioritize to reduce the client's risk of developing this life-threatening complication? Here are the options to consider. Option 1 is avoid stress-producing situations. Option 2 is avoid consuming alcoholic beverages. Option 3 is avoid eating complex carbohydrates. And option 4 is avoid getting too little sleep. The correct answer is option 1, avoid stress-producing situations. This is because Addisonian crisis occurs when the body cannot produce enough cortisol and aldosterone during periods of acute stress. Cortisol is critical for maintaining blood pressure, vascular tone, glucose metabolism, and electrolyte balance. When a stressor such as infection, trauma, surgery, or emotional distress strikes, the client's limited adrenal reserve can quickly become overwhelmed. Without stress-dose steroids, the individual can spiral into severe hypotension, shock, hypoglycemia, hyponatremia, and hyperkalemia. That is why teaching clients to avoid unnecessary stress, carry medical alert identification, and keep emergency injectable hydrocortisone available is the most important instruction. Turning to option 2, avoiding alcohol may be wise for general health, but alcohol is not a direct trigger for Addisonian crisis, so it is not the top priority. Moving to option 3, avoiding complex carbohydrates is actually harmful. These foods are beneficial because they release glucose steadily and help prevent hypoglycemia, which is already a risk in Addison's disease. Finally, with option 4, insufficient sleep can contribute to stress and lower immunity, but by itself, it does not directly provoke an Addisonian crisis. Therefore, stress avoidance remains the central teaching. Remember this Stan Coast pearl. Stress is the spark that ignites Addisonian crisis. Clients should know the early warning signs, such as severe fatigue, hypotension, abdominal pain, vomiting, and confusion, and act immediately with glucocorticoids. Your NCLEX high-yield takeaway is simple yet powerful. Alcohol use, diet, and rest are supportive lifestyle factors, but stress avoidance and preparedness with stress-dose steroids are the true life-saving interventions. Let us now shift into a priority-based clinical scenario. A client with Addison's disease is admitted to the hospital after experiencing persistent nausea and vomiting for the past 3 days. The healthcare team initiates intravenous methylprednisolone, a potent glucocorticoid, as part of the emergency management. The critical question here is, considering the pharmacologic effects of this medication and the client's underlying disorder, which nursing action should the licensed practical nurse prioritize in the plan of care? Here are the options for you to think about. Option A is to perform glucometer measurements at regular intervals. Option B is to monitor and document intake and output volumes. Option C is to obtain and record daily weights. Option D is to provide frequent oral care. The correct answer is option A, perform glucometer measurements at regular intervals. Here is the reasoning explained step by step. The primary priority is frequent glucose monitoring, because glucocorticoids, like methylprednisolone, directly increase blood sugar by stimulating gluconeogenesis, reducing peripheral glucose uptake, and creating insulin resistance. In Addison's disease, baseline glucose levels may already be unstable, especially after several days of vomiting and poor oral intake. Administering intravenous steroids can suddenly elevate blood sugar, placing the client at risk for hyperglycemia. If undetected, hyperglycemia can lead to dehydration, electrolyte imbalances, delayed wound healing, and a higher infection risk. Early and consistent glucometer checks ensure timely intervention, such as insulin coverage, and maintain safe therapy. For NCLEX memory, always recall this phrase, steroid equals sugar spike. Now, let us carefully examine why the other options are not the best choice. Starting with option B, monitoring intake and output is important because Addison's clients are prone to dehydration and hypotension. However, in the immediate context of intravenous glucocorticoid administration, the more urgent safety concern is acute blood glucose derangement, not fluid tracking. Intake and output is necessary, but not the highest priority. Moving to option C, daily weights are helpful in evaluating long-term fluid retention or loss, particularly in clients on mineralocorticoids. But this action reflects gradual changes rather than immediate metabolic shifts. Compared to hyperglycemia monitoring, it is lower on the priority ladder. Considering option D, providing frequent oral care supports comfort and hygiene but has no direct effect on preventing life-threatening complications of steroid therapy. On NCLEX exams, comfort-based tasks are distractors when compared to physiologic safety interventions. Linking this back to pathophysiology, Addison's disease is caused by insufficient cortisol and aldosterone production. Cortisol normally stabilizes glucose metabolism, vascular tone, and stress responses. During adrenal crisis, intravenous glucocorticoids restore essential cortisol function, but they also introduce risks such as hyperglycemia, gastric irritation, sodium retention, and potassium loss. This makes glucose monitoring the most critical intervention to prevent acute harm. Here is your NCLEX strategy takeaway. When multiple interventions are listed, apply Maslow's hierarchy and the ABCs. Pick the intervention that prevents immediate physiologic instability. In this scenario, checking blood glucose is the only option that directly prevents metabolic collapse. Oral care, weights, and intake output checks are important but non-urgent. Finally, let us wrap up with the Stan Coast Pearl. Steroid equals sugar spike. Anytime a client with Addison's disease receives intravenous steroids, make blood glucose monitoring the top priority for safe nursing care. Let us now move forward into another high-yield NCLEX clinical scenario. A 38-year-old client has been admitted with progressive features strongly suggestive of Cushing's syndrome, and the nurse begins the initial assessment to document the hallmark findings of chronic hypercortisolism. The question here is, which assessment findings should the nurse expect to document? The options include the client has very thin legs, the client looks emaciated, the client has bulging eyes, the client's skin is pale, the client has multiple areas of bruising, and the client's scalp hair appears thin. The correct answers are option 1, very thin legs, option 5, multiple areas of bruising, and option 6, thin scalp hair. Beginning with option 1, very thin legs. This is correct because Cushing syndrome causes prolonged glucocorticoid excess that accelerates protein breakdown in skeletal muscle. This results in pronounced muscle wasting, producing thin extremities in sharp contrast with central trunk and facial obesity. Shifting to option 2, an emaciated appearance. This is incorrect because although muscle wasting occurs, clients generally present with weight gain in the trunk, a moon-shaped face, and a buffalo hump. True emaciation is more characteristic of Addison's disease or malnutrition. Moving on to option 3, bulging eyes. This is also incorrect since exophthalmos is a key sign of Graves' disease due to thyroid hormone excess, not of Cushing's syndrome. Next, option 4, pale skin, is again incorrect because Cushing's typically causes fragile skin with a ruddy, flushed appearance and purplish striae. Generalized pallor is instead associated with anemia or adrenal insufficiency. Turning to option 5, multiple areas of bruising. This is correct because excess cortisol impairs collagen production and increases capillary fragility, leading to ecchymoses and delayed wound healing. Finally, option 6, thin scalp hair, is correct, since adrenal hyperactivity and androgen imbalance can thin scalp hair while simultaneously causing hirsutism in women on the face and body. From a clinical perspective, Cushing's syndrome often presents as a cluster of multi-system changes, including truncal obesity, moon face, buffalo hump, thin extremities, skin fragility, striae, easy bruising, osteoporosis, hypertension, hyperglycemia, mood changes, and increased infection risk. For NCLEX preparation, recognizing these hallmark differences is vital to distinguish it from conditions like Addison's disease and Graves' disease. Here is a Stan Coast Pearl to anchor this knowledge. Remember big belly, thin arms, fragile skin as the triad of Cushing's syndrome. This simple phrase highlights central obesity, wasted extremities, and fragile bruised skin, making it easier to recall under exam pressure. Let us transition smoothly into this advanced NCLEX-style question on Cushing's syndrome, which will not only test your knowledge of pathophysiology, but also your ability to identify priority nursing outcomes. A nurse is developing a plan of care for a client admitted with Cushing's syndrome, and the care plan includes the expected outcome. The client will remain free of infection during hospitalization. The question asks, based on the nurse's understanding of the disease process, which factors justify this expected outcome? The options to consider are, the client is at risk for skin breakdown related to thinning of the skin and edema. Wound healing is prolonged in clients with this disorder. The immunosuppressive effects of the disorder mask symptoms of infection. The client is at risk for aspiration and pneumonia related to laryngeal nerve damage. The client's admission white blood cell count is elevated, and the client's admission temperature is within normal limits. The correct answers here are option 1, option 2, and option 3. Now, let us carefully examine why each of these answers is right or wrong. Beginning with option 1, the client is at risk for skin breakdown related to thinning of the skin and edema. And this is correct. Excess cortisol promotes protein catabolism and collagen breakdown, which leads to thin, fragile skin, poor elasticity, and dependent edema. This fragile skin tears easily, increasing the risk of ulcerations and pressure injuries that become portals of infection. Nurses should emphasize meticulous skin care, frequent repositioning, and pressure relief strategies. Moving to option 2, wound healing is prolonged in clients with this disorder. And this is also correct. Cortisol impairs fibroblast activity, collagen synthesis, and angiogenesis, which are essential for tissue repair. Even minor wounds or intravenous insertion sites take longer to heal, thereby heightening infection risk during hospitalization. Shifting to option 3, the immunosuppressive effects of the disorder mask symptoms of infection, and this is another correct choice. Cortisol blunts lymphocyte and neutrophil responses, making typical infection signs like fever, leukocytosis, or redness less reliable. As a result, infections may go undetected until they become severe. Nurses must assess for subtle signs such as fatigue, behavior changes, or unexplained wound drainage. Turning to the incorrect responses, option 4 states that the client is at risk for aspiration pneumonia related to laryngeal nerve damage. This is incorrect because aspiration pneumonia is associated with thyroid or neck surgery, not with Cushing syndrome. Next, option 5 suggests that the client's admission white blood cell count is elevated. This is also incorrect. While cortisol may cause leukocytosis, the white blood cells are functionally impaired, making the count an unreliable indicator of infection defense. Finally, option 6 says the client's admission temperature is within normal limits. But this is not a justification for the outcome. Cortisol suppresses fever, meaning infection can still be present despite a normal or low temperature, making this an unreliable marker. Here is the clinical pearl you should always remember. Cortisol cuts collagen and immunity. In other words, excessive cortisol weakens the skin, delays wound healing, and suppresses immune defenses, all of which increase susceptibility to infection. In clients with Cushing syndrome, infections often present without fever or elevated white blood cell counts. So nurses must rely on subtle cues and prioritize skin protection, aseptic technique, and vigilant monitoring. Before moving to next high-yield NCLEX scenario, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exam successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep. Interactive live classes and easy to watch. Recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests. Ebooks and PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail. During comprehensive lecture, this isn't just another review. It's everything you need in one. Please scan the QR code right now, or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Let us dive into this NCLEX-style scenario with careful attention to detail. A physician orders a 24-hour urine collection to aid in the diagnosis of Cushing's syndrome, and the nurse must provide clear teaching to the client about when the collection should begin. The question asks, which statement by the nurse most accurately explains when the urine collection will begin? Here are the options to consider. Option 1, with the client's next voiding. Option 2, after the client's next voiding. Option 3, after drinking a pitcher of water. And option 4, with the first voiding in the morning. The correct answer is option 2, after the client's next voiding. To understand why, let us explore the reasoning behind each option. Choosing option 2 is correct, because a 24-hour urine collection always begins immediately after the client empties the bladder. That very first void is discarded to ensure the bladder is completely empty at the start, eliminating any urine formed before the test period. After that, every single void must be saved for the next 24 hours, ending with the final void at the exact same time the following day. This timing accuracy is critical in Cushing syndrome testing because the measurement of urinary free cortisol depends on complete collection. Elevated urinary free cortisol, usually above 120 micrograms per 24 hours in adults, strongly indicates hypercortisolism, whether caused by adrenal, pituitary, or ectopic sources. Missing even one void can make the results unreliable, which is why this teaching point is essential. Now, let us consider why option 1 is incorrect. At first glance, saying with the client's next voiding may sound logical, but this is inaccurate because that first void is intentionally discarded. If it were included, it would contain urine produced before the official collection period, creating false results. The nurse's actual instruction should be, urinate now, flush it away, and from this moment onward, save every drop until the same time tomorrow. Next, option 3 is also incorrect. Starting after drinking a pitcher of water is not a standard practice. While hydration is encouraged for better collection accuracy and kidney clearance, the test does not require forced fluid intake before starting. This distractor is meant to confuse test takers who may mix up timed urine collections with random urine samples that sometimes require hydration, like creatinine clearance studies. Moving on to option 4, this too is incorrect because beginning with the first voiding in the morning does not follow the correct protocol. Instead, the nurse instructs the client to discard the first morning void and then begin collecting all urine from that point onward. If the first morning void is kept, it blends pre-formed urine with new urine, disrupting the timing and risking invalid results. Here is a helpful stand coast. Pearl, think of that first void as a reset button, flush it away, then save every void for 24 hours until the same time the following day. Missing even one void means the entire test must be restarted. In clinical application, nurses should also remember to educate clients that urine needs to be refrigerated or kept on ice to prevent bacterial growth and breakdown of cortisol. Containers should always be labeled clearly with start and end times, and nurses should use gloves and standard precautions because of the large urine volumes being handled. Finally, from an NCLEX strategy perspective, whenever you see a question about timed urine collection, the safe answer is the one that involves discarding the very first void and then saving all others. This principle applies not only to cortisol for Cushing syndrome, but also to creatinine clearance, catecholamine testing for pheochromocytoma, and protein quantification. This is a high-yield test-taking clue to remember. Moving forward into the next high-yield scenario, imagine you are preparing to teach a client who has been scheduled for a 24-hour urine collection to evaluate endocrine function. The nurse must determine which statement most accurately reflects the correct procedure for handling and storing the specimen. Here are the options to consider. Option 1, the volume of each voiding is measured and recorded. Option 2, the urine is placed in a container of preservative and kept refrigerated or on ice. Option 3, each voiding is taken immediately to the laboratory for analysis. And option 4, the client voids directly into the large specimen container for accuracy. The correct answer is option 2, which is that the urine is placed in a container of preservative and kept refrigerated or on ice. Now let us explore why option 2 is correct. A 24-hour urine specimen requires strict preservation to maintain chemical stability and accuracy of results. The urine is collected in a large jug, often pre-treated with hydrochloric acid or another preservative, and it must remain refrigerated or stored on ice throughout the collection period. This prevents bacterial growth, decomposition of solutes, and pH shifts that could interfere with results. The first void at the start of the test is discarded to ensure the bladder is empty, and then every void for the next 24 hours is collected, including the final void at the same clock time the next day. This procedure is vital when testing for cortisol levels in Cushing syndrome, catecholamines in pheochromocytoma, creatinine clearance for kidney function, or proteins in nephropathy. Even a single missed or mishandled void can invalidate the entire test, which is why refrigeration and preservative use are essential. Turning to option 1, measuring each voiding volume is not required in a standard 24-hour urine collection. While measuring may sometimes be ordered for intake and output monitoring in fluid balance studies, it does not preserve chemical integrity and is not part of the laboratory's requirements for cumulative analysis. Considering option 3, sending each void immediately to the laboratory is unnecessary and incorrect. Laboratories require the complete 24-hour cumulative sample to calculate averages and total excretion. Sending portions separately would fragment the specimen, increase contamination risks, and prevent accurate analysis. Finally, let us look at option 4, where the client voids directly into the large specimen container. This is both unsafe and impractical. Clients should void into a clean container first and then transfer urine into the collection jug. Direct voiding raises the risk of spillage, stool, or tissue contamination, and skin contact with preservatives such as hydrochloric acid, which can cause chemical burns. For both safety and accuracy, indirect transfer is the correct approach. Here are some clinical pearls you must remember for the NCLEX. Always discard the first void, as this ensures a fresh start with an empty bladder. Collect all urine for the next 24 hours because even one missed void will invalidate the test. Keep the container refrigerated or on ice to prevent bacterial growth and chemical changes. Never allow the client to void directly into the jug due to safety risks. And remember that the specimen is sent only at the end of the 24 hours for cumulative analysis. And here comes your Stankos pearl. First void flush, final void finish. This easy phrase helps you recall that the very first void is discarded, while the last void completes the 24-hour cycle at the same clock time. Let us begin by unfolding this scenario step by step in a smooth narrative style, so it flows easily for the listener. After the healthcare team comes together to review the client's condition and nursing needs, they add the nursing diagnosis of disturbed body image to the care plan. Now, the key question arises. Which physiologic effect most commonly contributes to this disturbed body image in a female client with Cushing syndrome? Here are the options to consider. Option 1 is masculine characteristics. Option 2 is heavy menstrual flow. Option 3 is extreme weight loss. Option 4 is large, pendulous breasts. The correct answer is option 1, masculine characteristics. Let me explain why this is the best choice. Female clients with Cushing syndrome often develop signs of virilization, which means the appearance of male-like features. These include hirsutism, or excessive hair growth on the face and body, a deeper voice, acne, male pattern baldness, and sometimes clitoral enlargement. These changes occur because chronic hypercortisolism alters hypothalamic pituitary ovarian function and promotes relative androgen excess. This combination not only disrupts reproductive cycles, causing menstrual irregularities, but also significantly impacts a woman's self-image. For many, these physical changes become deeply distressing, making disturbed body image a central nursing concern. Now let us review why the other options are incorrect. Looking first at option 2, heavy menstrual flow. This is not typical of Cushing syndrome. Instead, women often develop oligomenorrhea or even amenorrhea because cortisol excess suppresses gonadotropin-releasing hormone and lowers estrogen levels. Heavy menstrual bleeding is usually tied to conditions such as endometrial hyperplasia or thyroid dysfunction, not hypercortisolism. Moving on to option 3, extreme weight loss. This does not fit the picture of Cushing's either. In fact, the opposite is true. Clients usually experience significant weight gain, especially in the trunk, face, and upper back, leading to what is described as truncal obesity, a buffalo hump, and a rounded moon face. While muscle wasting may occur in the extremities from protein breakdown, overall weight tends to increase. Extreme weight loss would more likely point toward conditions such as hyperthyroidism, advanced cancer, or malnutrition. Finally, let us consider option 4, large, pendulous breasts. This is not caused by Cushing syndrome. On the contrary, estrogen deficiency and irregular menses in these clients may actually lead to breast atrophy. Pendulous breasts are more often associated with obesity, genetic factors, or fibrocystic changes, not cortisol excess. Here is a high-yield clinical pearl to remember. Think of Cushing's as the cushion of cortisol. Excess cortisol creates cushion-like fat deposits in the trunk, face, and upper back, while at the same time causing skin thinning, purple striae, fragile capillaries, mood changes, and muscle wasting. And in female clients, the androgen excess manifests as masculinization, which is often the most troubling body image disturbance. And for your NCLEX tip, whenever you see a case of a female presenting with virilization, irregular or absent menstrual cycles, central obesity, and mood changes, always keep Cushing syndrome high on your differential list. This is the classic picture that ties directly into the nursing diagnosis of disturbed body image. Let us now move into another carefully crafted NCLEX practice question to keep sharpening your critical thinking skills. A client has been diagnosed with Cushing syndrome after diagnostic tests confirm excessive production of adrenocortical hormones. During teaching, the client's spouse asks about possible emotional and psychological manifestations. The key question is, which mental health concern should the nurse emphasize as most directly associated with Cushing syndrome? Here are the options to consider. Option 1 is anxiety and occasional panic attacks. Option 2 is depression and suicidal tendencies. Option 3 is impulsiveness and poor self-control. Option 4 is forgetfulness and memory changes. The correct answer is Option 2, depression and suicidal tendencies. Now let us explore why this is the most appropriate choice. Cushing syndrome is caused by chronic exposure to elevated levels of glucocorticoids, particularly cortisol. This may stem from an adrenal adenoma or carcinoma, an ACTH-secreting pituitary adenoma, Cushing's disease, ectopic ACTH production from malignancy, or long-term use of corticosteroid therapy. Cortisol plays a vital role in metabolism, cardiovascular regulation, immune modulation, and most importantly, central nervous system function. Excess cortisol disrupts neurotransmitters such as serotonin, dopamine, and norepinephrine, which directly control mood. This disruption, combined with distressing physical changes like moon face, truncal obesity, hirsutism, and muscle weakness, predisposes clients to major depressive disorder and even suicidal ideation. For this reason, depression is the most clinically significant psychological manifestation and requires continuous monitoring by the nurse. Turning now to option 1, anxiety and occasional panic attacks. This is incorrect because while clients may experience anxiety as part of their illness or due to lifestyle changes, it is not the hallmark psychiatric effect. Anxiety is more strongly tied to hyperthyroidism or generalized anxiety disorders. Moving on to option 3, impulsiveness and poor self-control, this is also incorrect, since these symptoms are characteristic of psychiatric illnesses like bipolar disorder, ADHD, or frontal lobe injury rather than Cushing syndrome. Finally, let us review option 4, forgetfulness and memory changes. Although cortisol excess can cause some degree of concentration problems or short-term memory lapses, these are not as prominent or dangerous as depression and suicidal tendencies, which remain the most critical concern. Here is the Stankos pearl you must not forget. Cushing's equals cortisol plus collapse of mood. Excess cortisol not only changes the body but also alters brain chemistry, leading to profound depression and even suicide risk. For NCLEX, always remember that mental health monitoring is as important as physical management in clients with Cushing syndrome. Let us now continue with another NCLEX-style practice question to strengthen your critical thinking. A client with Cushing syndrome is prescribed a low-sodium diet to manage complications related to hypercortisolism. The nurse knows that excess cortisol contributes to sodium and water retention, which leads to fluid volume overload, hypertension, and an increased risk for heart failure. To evaluate the effectiveness of dietary sodium restriction, the nurse must decide which action provides the most accurate and reliable indicator of therapeutic response. Here are the options to consider. The first option is monitoring sodium intake. The second option is measuring pedal edema. The third option is assessing skin turgor. The fourth option is weighing the client daily. The correct answer is option 4, weighing the client daily. Now, let us walk through the reasoning in detail. Cushing syndrome occurs due to chronic hypercortisolism, which may be caused by prolonged corticosteroid therapy, a pituitary adenoma known as Cushing's disease, adrenal tumors, or ectopic ACTH production. Cortisol increases sodium reabsorption in the kidneys, leading to fluid retention and expansion of extracellular volume. This commonly presents as hypertension-dependent edema, or in severe cases, pulmonary congestion and heart failure. Because of this, a low-sodium diet is prescribed to help reduce further fluid retention and ease cardiovascular strain. Looking at the first option, monitoring sodium intake. While it is important to track dietary adherence, it only reflects the process and not the physiologic outcome. Simply recording intake does not confirm whether fluid retention has decreased or if extracellular volume has normalized. Turning to the second option, measuring pedal edema, this method can give clues about fluid overload, but it is a subjective tool. Edema grading can vary between nurses, change with body position, or be less noticeable early on. It is therefore less reliable for consistent monitoring compared with daily weights. Considering the third option, assessing skin turgor. This is typically used to evaluate hydration and dehydration. In clients with Cushing syndrome, skin is often fragile, thinned, and has poor elasticity due to collagen breakdown, which makes turgor assessments misleading. It is not an accurate way to judge improvement in fluid excess. Finally, looking at the fourth option, weighing the client daily, this is the most accurate and sensitive way to evaluate fluid balance. A change of 1 kilogram equals approximately 1 liter of fluid gain or loss, making weight a precise outcome measure. In clients with Cushing syndrome, stabilizing or decreasing daily weights directly shows that sodium restriction is effective in reducing cortisol-driven fluid retention. For clinical integration, daily weights are the gold standard for tracking fluid retention. Nurses must ensure consistency by weighing at the same time every morning with the same scale, before breakfast, and in similar clothing. This ensures accuracy and allows subtle changes to be recognized early. Here is your Stand-Coast Pearl. Weight is the window into fluid balance. In clients with Cushing syndrome, daily weights reveal subtle changes long before edema or blood pressure shifts become evident. Let us smoothly transition into this next NCLEX-style question that focuses on the nursing management of Cushing syndrome. The question asks, a nurse is planning care for a client diagnosed with Cushing syndrome. Which interventions are most appropriate to address the client's basic needs? Select all that apply. Here are the options to consider. First, have the client sleep on a convoluted or egg crate foam mattress. Second, ambulate the client at frequent intervals. Third, advise the client to ask for assistance when getting up. Fourth, offer high carbohydrate nourishment. Fifth, check the client frequently for suicidal ideation. And sixth, instruct the client to wear loose-fitting clothing. The correct answers are options 1, 3, 5, and 6. Now, let us walk through the reasoning in detail. Cushing syndrome is a condition of chronic hypercortisolism, which may be caused by long-term corticosteroid therapy, pituitary adenomas, adrenal tumors, or ectopic ACTH secretion. Cortisol excess disrupts metabolism, weakens muscle tissue, suppresses immunity, and causes skin fragility. Clients face complications such as hyperglycemia, muscle wasting, thin skin, cardiovascular strain, and psychological disturbances. Nursing care must prioritize safety, skin protection, and mental health. Starting with option 1, using a convoluted foam mattress is correct. Because the skin of clients with Cushing's is fragile due to impaired collagen production, they are at significant risk for pressure injuries. A pressure-relieving mattress helps redistribute weight, prevent skin breakdown, and preserve integrity. Turning to option 2, frequent ambulation is not the right choice. Although mobility is important, muscle wasting and fatigue make these clients highly vulnerable to falls. Frequent ambulation without supervision increases injury risk, so activity should be balanced with energy conservation and safety measures. Looking at option 3, encouraging the client to ask for help before getting up is correct. Weakness, atrophy, and potential blood pressure fluctuations make falls common. By seeking assistance, the client reduces the likelihood of injury and supports overall safety goals. Considering option 4, offering high carbohydrate nourishment is incorrect. Cortisol already promotes hyperglycemia and insulin resistance. Extra carbohydrates would worsen this condition. Instead, dietary focus should be on protein to counter catabolism, low sodium to control fluid retention, and moderate carbohydrate intake. Next, option 5 is correct because frequent assessment for suicidal ideation is essential. Cortisol imbalance leads to mood swings, irritability, and depression. Added to the distressing physical changes of the disorder, these factors increase the risk of self-harm. Regular mental health screening is vital for safety. Finally, option 6 is correct since loose-fitting clothing protects thin, easily bruised skin from friction and pressure. This simple measure prevents trauma and supports skin integrity. To summarize with high-yield clinical takeaways, protecting fragile skin with pressure-relieving surfaces and gentle clothing is a priority. Fall prevention and asking for assistance safeguard weak clients. Mood assessment is as essential as physical care, and nutrition should emphasize protein and sodium control rather than carbohydrates. And here is your Stand-Coast Pearl. Cushing's clients need cushion and caution. Remember to provide cushion for the skin and caution with mobility and mood for holistic and safe care. Let us transition into the next clinical scenario to sharpen your NCLEX preparation. A client has just undergone a bilateral adrenalectomy for the treatment of Cushing's syndrome. During the immediate post-operative period, the nurse must carefully prioritize assessments to detect life-threatening complications early. The question asks, Which assessment finding is the most critical to monitor to identify complications promptly? The options provided are blood pressure, urine output, temperature, and specific gravity. The correct answer is option 1, blood pressure. Now let us walk through the reasoning step by step. To begin with, Cushing syndrome is a condition caused by chronic hypercortisolism, which may result from long-term corticosteroid therapy, pituitary adenomas, adrenal tumors, or ectopic adrenocorticotropic hormone secretion. When both adrenal glands are surgically removed, the client immediately loses natural cortisol and aldosterone production. This sudden loss places the client at high risk for Addisonian crisis, hemodynamic collapse, and electrolyte disturbances. That is why the immediate postoperative period is the most dangerous time. Focusing on option 1, blood pressure, this is the correct answer. Monitoring blood pressure is the highest priority because a sudden drop may signal hemorrhage, hypovolemia, or adrenal insufficiency. Since clients with Cushing syndrome often present with hypertension before surgery, any sharp decline in blood pressure afterward may be the first clue of vascular collapse. Timely recognition allows for rapid intervention, including fluid resuscitation, vasopressors, and corticosteroid replacement, which are life-saving measures. Turning to option 2, urine output, this is important but not the earliest indicator. Oliguria, or reduced urine output, occurs later as a consequence of sustained poor perfusion. It reflects secondary effects, whereas blood pressure changes directly reveal hemodynamic compromise in real time. Moving to option 3, temperature, this parameter is more useful for detecting infection. However, infections do not typically appear in the first few hours after surgery. They take at least 24 to 48 hours to manifest. Therefore, in the immediate period, temperature monitoring is not as critical as hemodynamic surveillance. Lastly, considering option 4, specific gravity, this reflects hydration status and fluid balance, but is not an early or reliable marker for acute postoperative complications in this scenario. It does not provide the urgent information that blood pressure monitoring does in the context of adrenal crisis. Here is the key clinical insight. Also known as the Stann-Coast Pearl, after a bilateral adrenalectomy, always remember the phrase loss of life-sustaining steroids. The earliest and most dangerous threat is acute adrenal insufficiency with vascular collapse. That makes blood pressure the fastest and most reliable marker of safety. Always place hemodynamic monitoring above other assessments during the critical post-operative window. Let us dive into the next NCLEX-style question with a strong focus on critical thinking. A client has recently undergone bilateral adrenalectomy as definitive management for Cushing syndrome. During the post-operative recovery period, the nurse must carefully evaluate for any signs of acute adrenal insufficiency. The question asks, which documentation finding provides the strongest evidence that the client has successfully avoided an Addisonian crisis? Here are the options to consider. Option 1, urine output is approximately 2,000 milliliters per day. Option 2, the client's pedal edema has lessened. Option 3, capillary blood glucose level is within normal limits. And option 4, vital signs are within preoperative ranges. The correct answer is option 4, vital signs are within preoperative ranges. This is because bilateral adrenalectomy abruptly removes the body's main source of cortisol and aldosterone, hormones vital for maintaining vascular tone, glucose metabolism, and fluid balance. Without them, the client is at risk of Addisonian crisis, a life-threatening emergency marked by vascular collapse, electrolyte imbalance, and shock. Stable vital signs provide the clearest evidence that the client has avoided this crisis. As the earliest and most dangerous feature of Addisonian crisis is severe hypotension unresponsive to fluids or vasopressors. Associated symptoms such as vomiting, diarrhea, abdominal pain, profound weakness, headache, and restlessness may follow. But the global indicator of stability always lies in hemodynamic balance reflected in vital signs. Now, let us consider why the other options are incorrect. Looking at option 1, urine output of 2,000 milliliters per day may suggest adequate renal perfusion, but it does not confirm adrenal stability. Excessive output can even suggest fluid imbalance or hormone deficiency. Turning to option 2, lessening of pedal edema is indeed a positive sign after hypercortisolism resolves, but it reflects long-term fluid correction, not immediate adrenal sufficiency. Moving on to option 3, a normal capillary glucose is certainly helpful, since cortisol is key for gluconeogenesis, and hypoglycemia is a crisis risk. However, one normal glucose reading is not enough to exclude Addisonian crisis, because levels can fluctuate with meals, fluids, or insulin therapy. Compared to the systemic stability shown by vital signs, glucose alone is not reliable. To reinforce this, here are some high-yield clinical pearls. The primary indicator of Addisonian crisis is severe, refractory hypotension and cardiovascular collapse. Other hallmark features include fever, abdominal pain, vomiting, restlessness, and profound weakness. For nurses, the top priority after adrenalectomy is frequent monitoring of vital signs and early initiation of corticosteroid and mineralocorticoid replacement. And finally, a NCLEX strategy tip: always select the finding that represents global systemic stability, like vital signs, over isolated or localized data. Stand coast. Pearl. When it comes to adrenal crisis, the blood pressure tells the story. Stable vital signs mean the storm has been avoided. Let us begin this question by focusing on a scenario that highlights a common surgical complication. A post-operative client with Cushing syndrome is recovering after an abdominal surgical procedure. The nurse understands that these clients face an elevated risk of delayed wound healing because hypercortisolism leads to fragile skin, impaired collagen synthesis, muscle wasting, and suppressed immune defenses. Now the question asks, during a dressing change, which nursing action is most critical to minimize the risk of wound dehiscence and promote optimal recovery? Here are the options to consider. Option 1, monitoring infusion of intravenous antibiotics. Option 2, removing tape toward the incision site. Option 3, increasing the client's dietary protein intake. Option 4, covering the wound with sterile gauze. The correct answer is option 2, removing tape toward the incision site. This is because Cushing syndrome causes tissue weakness and reduced tensile strength. If the nurse pulls tape away from the incision, it places mechanical tension on sutures and fragile skin, raising the risk of wound edge separation. By carefully pulling tape toward the incision, the nurse protects the sutures, reduces mechanical stress, and preserves wound integrity. This intervention directly addresses the most immediate and critical risk in this post-operative situation. Looking at why the other options are less critical, let us start with option 1, monitoring infusion of intravenous antibiotics. While infection control is always essential, this task is part of routine care and does not specifically target the most immediate risk for this client, which is wound separation due to tissue fragility. Next, consider option 3, increasing the client's dietary protein intake. Adequate protein supports collagen formation and tissue healing, but its benefits occur gradually over time. In contrast, incision disruption can occur instantly if the wound is mishandled. So, nutritional measures are secondary. Finally, option 4, covering the wound with sterile gauze, certainly protects against infection, but it cannot reverse or prevent the mechanical stress caused by improper tape removal. If the wound edges separate, sterile coverage is not sufficient to prevent complications. Here is a stand coast pearl to remember. Think of fragile frame in Cushing's. The skin and sutures are like a delicate picture frame that can easily crack under pressure. Gentle handling during dressing changes is the frontline strategy to preserve that frame. And here is the NCLEX high-yield takeaway. For clients with Cushing syndrome in the post-operative period, the highest priority is incision integrity. Always handle dressings gently, pull tape toward the incision line, and reduce mechanical stress on fragile tissue. While antibiotics, protein intake, and sterile coverage play important roles, the immediate and most critical intervention is protecting the wound from dehiscence during dressing care. Let us continue building your 75-question NCLEX script. And here is the next case for narration. A client who recently underwent a bilateral adrenalectomy is preparing for discharge, and the nurse must evaluate the client's understanding of the lifelong implications of this surgery. The question asks, which client statement demonstrates the best evidence of appropriate learning? Here are the options to consider. Option 1, I should avoid people with infectious diseases. Option 2, I need to limit my fluid intake to 1 quart per day. Option 3, my appearance will never be the same as it was before. Option 4, no other treatment is necessary after I recover from surgery. The correct answer is option 1. I should avoid people with infectious diseases. This response shows the most accurate understanding of life after a bilateral adrenalectomy. When both adrenal glands are removed, the body loses its natural production of cortisol and aldosterone. Cortisol plays a key role in regulating immunity and inflammation, but lifelong replacement therapy with hydrocortisone, prednisone, or fludrocortisone blunts normal inflammatory responses. This means that even serious infections may progress silently, without redness, swelling, or fever. Clients must therefore be vigilant with hand hygiene, avoid exposure to infectious individuals, and seek medical attention early for any subtle signs of illness. Recognizing this risk demonstrates that the client understands the lifelong implications of immunosuppression and infection prevention. Now, looking at why option 2 is incorrect, the statement about limiting fluid intake reflects a dangerous misconception. Without aldosterone, the body cannot conserve sodium and water, placing the client at risk for fluid volume deficit and hypotension. Restricting fluids would worsen dehydration and could trigger an adrenal crisis. Instead, clients must maintain adequate fluid intake and sometimes even increase sodium intake during illness, exercise, or hot weather. Moving on to option 3, saying my appearance will never be the same, shows a misunderstanding. Clients with Cushing syndrome often have a Cushingoid appearance, with features such as a moon face, truncal obesity, striae, and thin skin. After adrenalectomy and proper hormone replacement, these features typically improve as cortisol levels normalize. While minor changes may persist, most physical characteristics recover over time, making this statement unnecessarily pessimistic rather than accurate. Finally, examining option 4, the belief that no other treatment is necessary after recovery is dangerously false. Removal of both adrenal glands leaves the client permanently dependent on lifelong steroid replacement. Without glucocorticoids and mineralocorticoids, the client would experience adrenal crisis, marked by profound hypotension, shock, and even death. Clients must be educated to wear a medical alert bracelet, carry injectable hydrocortisone for emergencies, and increase steroid doses during times of stress, trauma, or illness.